صباح الخير، سامعني كده كويس؟ Good morning everybody. احنا I'm going to present my panelist. I'm going to go through alphabetical order. Dr. Hanady bin Hani, Assistant Professor of Speech and Hearing Science, University of Jordan. Professor Hegazi, Professor of Phoniatric Ain Shams University, and Professor Dr. Somia Tawfik, Professor of Audiovestibular Medicine, Ain Shams University. We're going to have a quick introduction and we'll go through all these titles. These titles are comorbid with the APD. So there is an intimate relationship between language, attention, and auditory skills. Auditory processing disorder often coexists with other difficulties like learning, language, and attention deficit. Just to remind me quickly, this is a known definition that how well the ears talk to the brain and how well the brain understands the ear. And this goes through different abilities, starting from bottom up and top down, starting from localization and ending by cognition, timing, and discrimination in background noise. Any disturbance in these abilities result in auditory processing disorder. So APD could be divided either primary or isolated, secondary due to peripheral hearing loss, and I'm going to have a panel after this round table for this classification, and lastly the comorbid, the round table of today, of now. The comorbidity, comorbid means looks alike. They share symptoms and signs. And by studies that we found, their common comorbidities were found like the ADHD, dyslexia, autism spectrum disorder, SLI, delayed language development, learning disability with different percentage of appearance with the APD. So it's worth it that we have to work multidisciplinary in order to go through these comorbidities and to understand them, to assess them and management. May I call my first panelist, Dr. Hanady, please to the stage.
Good morning, everybody. Thank you for being here today. My topic is about autism spectrum disorder and APD. I decided today to talk about similarities and differences between the two disorders, which is a bit critical. It's a bit hard to really distinguish. And that's one way of looking at how to look at the diagnosis. I'm going to start with the definitions. ASD is a neurodevelopmental disorder that affects children in many areas, specifically in social interaction. They have repetitive behaviors, restricted interests, and that affects about 1 in 36% of the children. As for the APD, as discussed earlier, it's the processing problem is in the auditory system. The brain, how does it get the sounds? How does it perceive the sounds? So the prevalence of the APD depends on the what the study suggested. It varies between 0.5 to 7% in the population. Both disorders, they occur more in boys than girls. For girls, it's for ASD, it's 4:1 ratio. As for APD, it's 2:1. The core challenges in ASD, basically, it's the social communication aspect. The social communication aspect, it varies rapidly between the population. So we have those kids who don't want to communicate. They are isolated. They don't have eye contact. They don't have backward, forward conversation. And we have those who are communicating, high functioning. However, the way they communicate is not up to the standards of the social aspect. For today, what I'm discussing is more about those who have severe or the difficulty with ASD that is related to language impairment as well. The other core behavior is the repetitive behavior, where we see the kids flapping, lining up toys, spinning around. and the sensory processing aspect. For the sensory aspect, we see that they might have hypersensitivity or a hyposensitivity that's related to sounds, touch, smell, visual stimulus, so they differ based on the case. One of the core things I see in the clinic for kids with autism is their difficulty in transition. I usually see inflexibility. They want to have the same routines. They want to have things their way. It's hard to change from one activity to another. As for APD, the problems we see in APD, basically, yes, they suffer with language, with understanding the language, as in certain circumstances, especially when it's noisy, multiple speakers speaking at the same time, fast speech, and that would affect their ability to process the multi-direction tasks as well. We'll see that they have problems with the discrimination and phonological awareness of sounds. And in the cases where we don't have early intervention, we're going to see language delay, weak vocabulary, poor sentences in their speech, and we usually will see the articulation errors because they don't really perceive the sounds in a proper way. So, as for the differences between the two disorders, first of all, it's the focus of the disorder, the identification of it. As I mentioned, ASD is a neurodevelopmental disorder, and we see the difficulties in different areas. As for APD, the main complaint is about how the brain processes the sounds and language. In ASD, the core deficit is the social interaction. Even if they develop the language, we'll find that these kids don't communicate the way they should. They don't know the rules of communication, while in APD, this is not the main complaint. Another thing is the response to sensory input. For ASD, the sensory hyper or hyposensitivity is one of the core behaviors we see, and it's not only related to sounds. It's also it can also be related to visual stimulus, touch, or light. For APD, it's most probably what we're going to see is oversensitivity to the sounds. As for the behaviors, we're going to see the repetitive behaviors, the inflexibility in ASD, but we don't regularly see it in APD. Back to language delay. For ASD, around a third of those kids are not going to develop language, or they're going to be minimally verbal. As for APD, if we provide the intervention and if we fix the environment, reduce the noise, make sure you use the FM systems. Other accommodations in the environment might help develop the language. Time, I'm okay? Time? Yeah? Okay. So there is overlap between ASD and APD. We'll find that both don't understand spoken language. They have difficulty following the instructions. They struggle with the conversation. But when we look inside the disorders, we're going to see that these disabilities or these characteristics, the source of it is different between ASD and APD. ASD, the social context itself is challenging, while for APD, it's the processing of the sounds what's giving them these difficulties. And for APD, as I said, if we control the environment, provide the training, we might see progress in general. The social cues in ASD and in APD is, we find the problem in the social cues, especially in the vocal cues like tone of voice, pitch, and emphasis. However, in ASD, the studies show that they have high ability to discriminate these different vocal cues, while in APD they don't. And definitely we're gonna see the auditory discrimination problems. Okay, so that leads us to how the similarities and differences work in ASD and APD. We know that both we have in ASD, it's a spectrum. There's a variability, huge variability between the children. And in APD, it's comorbid with other disorders. Therefore, definitely we need a multidisciplinary approach. So for autism, we're gonna need a full team. We need pediatric, we need an SLP, psychologist, OT, audiologist, all to look at, is it ASD? Are the symptoms there? And what's happening aside from the ASD? As for APD, again, the main role goes to the audiologist to check if this is auditory processing disorder. We need SLP to look at the language, psychologist to look at IQ. I'm done? Okay. Physician, teachers, and caregivers. So in conclusion, when we look at ASD and APD, the overlap is huge. It's really critical to look at each disorder separately. We know that 80% of children, as estimated by parents, might have sounds processing problems. And we know that a third of the kids with autism, they don't acquire language. Therefore, it's really important to figure out a way to differentiate the two conditions. We need a team. And maybe for the future aspects, we really need to look at behavioral and the brain imaging at the same time to figure out what's really happening. Are the kids with ASD suffering from APD as well? And that's what's preventing them from acquiring language, or they are totally separate disorders. Thank you.
Thank you. Thank you. Thank you, Hanady. Now, Professor Dr. Bani Hegazi, specific language impairment and language learning disability, relation to auditory processing disorder. Please, Dr. Bani, time.
Good morning, everybody. Good morning, everybody. I'm glad to be with you again with my friends and beloved ones in the audiology. I'm going to speak in this panel, roundtable about language, or specifically SLI, together with dyslexia and the relation to APD. So, I'm going to describe the two disorders briefly. I'm going to relate them to each other, and I'll try to evaluate how the three disorders, what's the relationship between them. What's developmental language disorder? This is the new terminology that has been used lately instead of SLI. Whether we should use it instead of or another as another definition or terminology, this will depend on, of course, as we know, they both are characterized by difficulties in the acquisition and the use of language, with deficits in both the comprehension and the production of all language structures. But what's the difference between them? The difference between them is that the newly developed definition, which is DLD, uses an IQ cutoff 70. IQ 70. So if we find an IQ of 70 or above with delayed language development, we will consider them as developmental language disorders. Whereas the specific language impairment says that the IQ has to be above 85 in order to consider the specific language impairment terminology. Of course, there are political reasons for why they included the 70 and above in this terminology and in this definition, but we have to abide in a certain way. But until then, we have the previous definitions for SLI still stand. The etiology of SLI is probably multi-gene source on chromosome 7. This is the most accepted theory. But we have to know that there are multiple routes are involved in language acquisition. These include effective general processing speed, effective auditory processing, environmental stimulation, and effective short-term memory. If one route is blocked, it's okay. The child can develop language. But if more than one route is blocked, then language learning will be very compromised. There are multiple theories for the causation of SLI. One of them is the temporal processing disorder theory. And of course, we all know what it is. And I have to say that when it is present, it will affect phonology acquisition, syntax, semantics, and even production of language. There are other theories. This is no time for discussing them. But what are the criteria? When do we diagnose SLI? When the receptive age is 6 months or more, less than the chronological age, or when the expressive language age is 1 year below the chronological age, at least 1 year below the chronological age. Then with IQ, of course, not less than 85. Then we can diagnose SLI. What about the second disorder? It is a specific learning disorder, and this is by definition, it has to be a problem affecting the processing of reading, which is called dyslexia, writing, which is called dysgraphia, and or math problem, which is called dyscalculia. The prevalence is from 5 to 15%. In order, this is about the prevalence of specific learning disorders in general. We consider that dyslexia accounts for the majority of learning disabilities, constituting 80% of the learning disabilities. Of course, as you know, that dyslexia affects the reading, the ability to write, of course, as a consequence of a reading problem, and affects spelling too. The prevalence spans from 1 to 33% of the population, which is a very big span of prevalence. But however, the most accepted is that it may affect 5 to 10% of any given population. There are multiple theories. The auditory processing disorder theory, of course, it is one of them, as evidenced by many, many researchers. There are other theories. There is no time to discuss them. How can we diagnose dyslexia? Dyslexia is a reading or spelling age that is significantly behind the child's chronological age. It's usually 2 or more years behind. Usually, we know that the children begin to decode. They begin to يستهجوا كلمة علشان يقروها at around the age of 4 to 6 years. This is the classical approach. So it's diagnosed when a child cannot read as expected for his academic year. The other presentation is that it's an early diagnostic approach or early presentation approach. With this approach, we can very early, when the child is even less than 4 years, we can find that the child has some phonological problems, phonological awareness problems. For example, if we say to the child, I'm going to say a word that is cut into 2. Rabbit. What is this word? The child has to recognize that I'm saying rabbit. Okay? If the child very early cannot do this, then I have to doubt that this child might have a phonological awareness problem and is reflected on reading as well. What's the relationship between the different disorders? Here's a relationship between SLI and APD. I like this model. There are possible 4 relations, either that they are 2 distinct disorders, either they are the same disorders but they carry different names, either or that SLI is a subset of APD, or the opposite. So any of these constructs may be the truth. somewhere or somewhere between this. What about dyslexia and APD? We know that 42% of children with APD have dyslexia, while 39% of dyslexic children have APD. So we have a 40.5% overlap. What about dyslexia and SLI? 55% of children with dyslexia have a language problem, and 51% of children with SLI have a reading disability, so there's an overlap of 53%. What are the questions to be posed? Are they distinct disorders? These three disorders? And the other question is, should we refer all cases of SLI and dyslexia for auditory perceptual assessment? A question that we clinicians have to ask ourselves. We have to sit together and decide. However, it is clear that APD often co-occurs with impairments of language, literacy, and attention, as well as we will hear from Professor Dr. Somia. So we need to work collaboratively in order to find the solutions for all our questions. Thank you.
Thank you, Professor Mona Hegazi. And now our last presentation by Professor Somia Tawfik, one of the pioneers in central auditory processing in Egypt and Arab world. She's going to discuss attention deficit disorder and APD.
Good morning. I would like to thank Dr. Amany for organizing this interesting roundtable and the speakers. My talk will be about one of the most common comorbid condition. The sound is clear. Comorbid conditions with auditory processing disorder, which is attention deficit hyperactivity disorder. The key points that I'm going to cover is to highlight on ABD and ADHD and the link between them, clinical presentation, and I will add how to manage such comorbid conditions with a concluding comment. This is let's first define auditory processing disorder. It is a deficit in the processing of auditory information and the neurobiological activity underlying that processing. The brain cannot process the auditory information, resulting in attention problem, discrimination problem, and the subject cannot comprehend the auditory information. On the other hand, ADHD is one of the most common neurodevelopmental disorders in children, where the core symptoms is the same as ABD, inattention. But we have other clinical presentation, distractibility, difficulty, impulsivity, difficulty in controlling impulse, hyperactivity. This is according to the most recent definitions of DSM-5 2024. So ADHD is one of the most common neurodevelopmental disorder. It affects about 11% of children, and it affects boys more than girls. And the average age of detection is about 7 years. Unless it is so severe, it will be detected in younger age. What are the traits of ADHD? ADHD has two main traits. The first was attention deficit hyperactivity disorder, characterized by mainly hyperactivity with inattention and impulsivity. The most recent or outdated trait is ADD, where there is inattention, impulsivity with no hyperactivity. If we look for the two disorders, how they look similar and dissimilar, we see that ADHD is characterized by inattention, distractibility, and ABD also is characterized by by inattention distractibility. In addition to the other clinical findings, here I would like to focus, they look like, but they have same or similar criteria, because inattention will affect performance at school. The subject in social situations cannot communicate. He will be out of the loop. And the problem, is this ADHD or ABD? They are too similar, and linked to each other, but they are different. They are not the same. They can coexist together, but we should be able to differentiate between them. ABD is characterized by inattention in certain challenging situations, not all the time, like noisy situations, rapid speech, reverberant conditions, and resulting in discrimination and comprehension problems. While ADHD, the subject is inattentive all the time, not in certain situations, with distractibility, impulsivity, and hyperactivity. So they are different, and they can coexist together. So long as they are different, they can coexist together. And about 41 to 55% of children can have comorbid conditions of ADHD and ABD. Now let's talk about how to differentiate and what to do for this group of children who have ABD comorbid with ADHD. First step is to do tests to confirm ADHD. We have a very interesting test called Auditory Continuous Performance Test for measurement of sustained attention. If the sustained attention is affected, this child most probably have ADD. And then if we suspect this, we refer the child to pediatric neuropsychiatry for adequate control of the condition. And there are many tools for management by medication, parental and school counseling. Once the condition is controlled of attention deficit disorder, we go ahead and do auditory processing assessment using psychophysical and electrophysiological testing. And here we should also refer for speech and language assessment. Re-evaluation of these children showed very interesting findings. Most of them, احنا دخلنا على thank you على طول. Re-evaluation of these children showed very interesting affection of auditory abilities, attention, especially sustained, as I mentioned, and auditory selective attention. We have research studies showed affection of auditory selective attention, that's attention in background noise, affection of memory, and temporal processing deficits. So if these children show deficits in these abilities, we can implement a protocol for management, including training of the affected auditory abilities and other strategies like environmental modification, like higher order cognitive strategies. In conclusion, comorbidity between ABD and ADHD is well documented. Evaluation of auditory processing abilities should be implemented in the protocol of children with ADHD. And actually we have a protocol in collaboration with neuropsychiatry where they have been referring this group of children, and we have very interesting data showing that a large percentage, 50% or more, have comorbid conditions. Whether the child receives, and this is the last conclusion which is very interesting, whether the child receives the diagnosis of ABD or ADHD depends on whether the audiologist or the neuropsychiatry assess the subject first. If an audiologist assess, he will say he has ABD. If a neuropsychiatry, he will say he has ADHD, because they are very much look like, but they are not the same. They are comorbid conditions. Lastly, multidisciplinary approach, and I think Dr. Amany will focus on this, is the key for management of ABD and comorbid disorders. Thank you.
والمفروض في slide بس for the sake of okay. For the sake of time we can figure out from the presentation. Okay, from the presentation how far those disabilities intermingled and are similar in so many things. And if we psychologists go and treat the ADHD without going to the main core with APD, the children will not take the proper management, and the same for the autism, and the same for the dyslexia and delayed language. So I think to conclude and to take home message, the multidisciplinary not only for assessment, but to put guidelines to the referrer when to refer. Not all the children should be referred. This is number one. Number two, we have to modify the test, the assessment, the testing protocols, not the regular APDs, because some of these children will not have language like the ASD or have delayed language. So there will be a modification in the testing. And finally, we'll tailor a management protocol according to each comorbidity. So the multidisciplinary approach is mandatory in the diagnosis and management of APD and comorbid condition. Thank you.
Thank you, Professor Amany. I would like to thank you personally for the selection of this topic. It was very interesting. Such comparisons make things very obvious, the overlappment and the differences. Thank you for all the speakers. It was really more than excellent. Thank you very much. And this ends our session. And I think we have to move to hall 1 because of the symposia of the companies now.